how can we intervene with MRD-directed therapy, especially in the setting of MRD-positive disease, both within and outside the transplant setting? And I think this is where the field is going. We know that MRD-positive patients tend to do better after a transplant than if they don't get transplanted because of the high risk of disease burden and relapse. What we don't know much about is whether intervening prior to transplant or instead of transplant could have a beneficial impact as well with more targeted therapies. So I'd like to kind of address this question just briefly. Are we at a stage where we can intervene with MRD-directed therapy in an effective way? And maybe I'll just jump over to Dr. Miyazaki if she has an opinion on this particular question, and if there's any role in MRD-directed therapy in your practice.
In our practice, MRD for AML is not well established in Japan, unfortunately, except for CBF and NPM1. Flow cytometry system is not good in Japan for MRD for AML patients. So because NPM1 and CBF, they tend to be a favorable prognostic AML cases. So we do not do much transplant issues. So we use the risk stratification at diagnosis to choose transplant treatments. That's the situation.
Thank you. And then Dr. Gail, your oral AZA study showed that there's the ability to convert some patients with MRD positivity to negativity. Do you view that as a strategy to consider for some of these MRD positive patients? Obviously, in a non-transplant eligible patient who's getting maintenance therapy, it doesn't create maybe a decision point, but in a transplantable patient, for example, or maybe is a question about duration of oral azacitidine therapy. Do you think that that's an important consideration, and how are we addressing patients that are able to convert from MRD positivity to negativity, and what's been your experience in that setting?
So I want that to be what we do and what we know how to do, but I think that fundamentally that gets back to the really core question of the assay. So in QUAZAR, in this study that looked at oral azacitidine, the conversions were that are reported or measured by flow. And it is still fundamentally the case, and I think Roland alluded to this a minute ago, that is an MRD negative patient the perfect patient to transplant or to not transplant, right? And depending, I can convince you, I can be pretty convincing, I can convince you of either of those, right? You have an MRD negative patient, that's a great reason not to do an allo transplant, and it's also a great reason to do an allo transplant. I think everything that has been said so far is the case, that the conversion right now by flow is iffy. We're not sure. If you look even at intensively treated patients, and this happened on the QUAZAR trial, that there were patients converting from positive to negative flow, even on the placebo arm. And the reason for that is a matter of testing, that if depending on when you test somebody after they've had chemotherapy, you could potentially be 2 months out from a cytarabine-based consolidation and still detect a so-called conversion to MRD negativity. That said, it is absolutely the case that there are patients on oral azacitidine who get it, who convert, and then those patients have decision-making as to whether, well, maybe this is the perfect time for me to get a transplant, or it's the perfect time for me not to get a transplant, and that is some individual decision-making. But I think that if we have better tests, I think it is going to go the way of using the test, following the patient in a long-term way that Uwe was actually alluding to. And if we know that the disease is going to respond again, which is the $50 billion question, then we might do this. I haven't stopped my patients yet. I haven't. I don't trust it yet, because I'm not sure that if the disease comes back, that I haven't had my fingers successfully on, covering the dam, and if I let it go, that they're going to relapse with something horrible. But we are getting closer. And the clinical trials, by the way, this is just a plug for what some of us are doing in different ways to try to get MRD as an actual endpoint for clinical trials, because a lot of trials have died on the vine. If you look at the maintenance trials, most of them have closed. They haven't been able to accrue or get started, because if you don't have MRD as a definitive endpoint, then the drug company has nothing to target in a clinical trial. Andrew Way and others working on Intercept and other large trials trying to look at MRD erasers during therapy are ongoing. But until we know that we have something that is an actual endpoint, like for blinatumomab, if you have something that you get rid of it and it makes life longer, you have a not only a prognostic, but a predictive power. If we have that as an endpoint, that's what's going to be the game changer in the maintenance space.
And then, of course, we have the whole array of targeted therapies to consider, as well as potential MRD-directed therapies for our patients that carry certain targetable mutations or molecular abnormalities. That certainly is an area that is in its infancy as it pertains to erasing MRD and becoming a preferred therapy in that setting. So we'll have to stay tuned for more data as it emerges in this field. I think with that, we'll wrap up this discussion, and I want to thank everybody for some outstanding input and questions, and hopefully this has been helpful to maybe not clarify everything, but to give people an understanding of kind of where the field is and how complex it is.
Jeff, I think you did an amazing job outlining these questions. I think the questions give more questions than answers, but that's kind of where the field is. I think before we segue, though, Charlie, I saw your hands up, so thank you for joining. I know you had a monster.
Sorry, I didn't see it. Yep.
So. Yeah, thanks, Gail, and thanks, Jeff. I was just going to make two comments. The first is this question that Naval raised about, drawing parallels from other diseases, which I think can actually be very misleading. John Goldman's wise advice was around CML that it's perfectly possible to discontinue imatinib because you know that when relapse occurs, it's orderly and salvageable. And you have to be absolutely confident about that. So I don't think we can learn too much from other diseases, and these are AML-specific decisions. But Jeff, to your point about how does MRD change how we transplant, I think it's going to be very difficult to design studies to talk about whether intervention in MRD-positive patients improves transplant outcome. And I kind of leave that on one side because just trial design is so challenging. But I think it certainly does influence how we transplant, use of myeloablative or a RIC. But particularly the Morpho study was transformative, because if you're MRD positive, you need gilteritinib maintenance. If you're MRD negative, it does you harm. And I think one of the areas that we need to focus our research on going forward is to define the optimal timing of post-transplant MRD assessment, because it's very clear that the current approach of doing a bone marrow aspirate on day 100 that we all inherited, in high-risk patients, that's looking too late. And plausibly, I think in very high-risk patients who go through transplant, early MRD can be a very good guide for rapid tapering of immunosuppression, and actually the use of DLI, which can be a highly effective therapy in the MRD setting. So I think it will change how we monitor patients, how we deliver transplant, but we do need some prospective comparisons. Thanks, Jeff.
No, thank you so much, Charlie. That was incredible input and something that we needed to hear more about with regard to how this affected the actual transplant procedure and post-transplant management. So thank you for that.